Okay, welcome. Let's talk about approach to edema in a neonate. So edema is excess fluid in the extravascular space. So if you see this diagram, this is a capillary bed, and on the capillary bed, the blood is coming from here, and it's going out through here. So this is the arterial, this is the venule, and for the factors that affect the loss of fluid into the extravascular space is the hydrostatic pressure, which is pushing water outside. So this is hydrostatic pressure, which pushes water outside, and the force that draws water inside is the oncotic pressure. Then we also have the permeability of the capillary membrane, and the extravascular fluid is drained through the lymphatic system. So this is the lymphatic system which drains the extravascular fluid. So factors that cause edema affect either the hydrostatic pressure, so increased hydrostatic pressure, reduced oncotic pressure, then increased capillary bed permeability, as well as lymphatic blockage. Those are the mechanisms from that diagram that can show us how edema arises. And so the fifth cause is a complex mechanism, and that's myxoedema. So we start by talking about increased hydrostatic pressure. So for a neonate, increased hydrostatic pressure occurs if there is a decreased venous flow, and this can occur if there's heart failure and the heart muscle is not functioning well. The blood return to the heart is compromised, and this causes increased venous pressure, and eventually pressure is increased. Hydrostatic pressure increases in the capillary bed, and this can cause extravasation of fluid and lead to edema. So the mechanisms of edema, if we're referring to our diagram, there is increased hydrostatic pressure, reduced oncotic pressure, increased capillary permeability, and lymphatic blockage. So those are the four: increased hydrostatic pressure, reduced oncotic pressure, increased capillary permeability, and lymphatic blockage. Those are the four mechanisms by which edema occurs. And the fifth mechanism is myxoedema, but this occurs by deposition of glycosaminoglycans in the skin when the patient has hypothyroidism. Then we start by talking about increased hydrostatic pressure. And increased hydrostatic pressure we can occur with venous stasis, and this can occur usually with the right heart failure. We can see the edema and the swelling of the liver. But with the left heart failure, it can also occur cause pulmonary edema. This you won't be able to see it on the lower limbs, but on chest X-ray or auscultation you can hear. So increased hydrostatic pressure, this can occur with venous stasis, and like we said, then with volume overload, this is occurs usually with renal failure in neonates, and this could be in males. This could be secondary to posterior urethral valves that can cause that, and you also see syndrome of inappropriate ADH secretion, which can be okay if the patient has got pneumonia or if the patient has got meningitis. Then we talk of also congenital adrenal hyperplasia, which can lead to sodium retention and volume overload. So eventually, if the plasma volume is high, this can cause edema. Okay. Then the other cause is a reduced oncotic pressure, and this can occur with a congenital nephrotic syndrome or liver disease. So with congenital nephrotic syndrome, it can be primary or secondary. So the third mechanisms by which edema occurs is increased capillary permeability, and in neonates it's going to be seen with neonatal sepsis. It could also be seen with hypoxia, and it could also be seen with acidosis or after severe hypothermia. So you usually see babies that are asphyxiated after bacterial asphyxia can actually present with edema. You see that a lot. Asphyxiated babies develop edema, then acidosis, and severe hypothermia can also increase capillary permeability. You may also need to know that even premature babies are prone to edema because of increased capillary permeability as compared to term babies. So premature babies, even if you are just giving them routine fluids, can develop edema because of the capillary permeability, which is higher. And the fourth mechanism of edema is lymphatic blockage. And in a neonate, lymphatic blockage is caused by Turner syndrome. So this is a condition where the karyotype is 45XO. So they have 45 chromosomes, and in this condition, because of the karyotype, they are females. They will always be females. But there is a condition which closely mimics Turner syndrome, known as neonate syndrome, and this can occur with males. So if you see a female with a lymphoedema, that's more likely to be Turner syndrome. If it's a male, then it's more likely to be neonate syndrome. So the characteristic of lymphoedema is that it's non-pitting, like we saw from the diagram, that the extramuscular fluid is supposed to be drained through the lymphatic system, and if it's blocked, this will make sure that the excess of vascular fluid will not be drained. And finally, the fifth mechanism of edema in a neonate is myxoedema, and this can occur with hypothyroid. This occurs always with hypothyroidism, and the mechanism of myxoedema is to do with the deposition of glycosaminoglycans. I will not go much on that. What I'm going to say is that the features of hypothyroidism, they include umbilical hernia. The baby will have reduced activity. It is very common in Down syndrome, and some of the babies can actually have the hoarseness of the voice, and of course the myxoedema. So if you see a baby with edema and the umbilical swelling, as well as reduced activity and Down syndrome, if you examine this baby, you may also see splaying of the fontanelle. So splaying of sagittal sutures, splaying of coronal sutures. Those features can show you that this baby may have. So history taking in a neonate with edema, we start with pregnancy. In pregnancy, we want to ask if the maternal age, okay, because we know that some congenital heart problems can occur with advanced maternal age. I also want to ask of previous histories of miscarriage in the mom. We know that recessive compatibility and other things can cause hydrops fetalis and edema. Then we want to ask of the history of syphilis and HIV. This can cause congenital nephrotic syndrome. You also want to ask of antenatal ultrasound scan. An antenatal ultrasound scan can show us oligohydramnios, which is can occur with the renal problems, or hydrops fetalis, which we said is this edema that can occur in pregnancy. Delivery, we want to know the sex of the baby. If the baby is a boy, they are prone to posterior urethral. They may be having posterior urethral valves, so we need to check for that. The birth weight, we know that low birth weight is associated with congenital infections, that is torches. And torches infections usually cause edema by causing congenital nephrotic syndrome. And the other issue with birth weight is that also other congenital dysmorphic morphism can present with low birth weight. And this congenital dysmorphism may be associated with congenital heart disease. Then we also want to ask about the Apgar score at birth, and with today's asphyxia. This usually shows that the patient is prone to edema because of increased capillary permeability. Then also ask of birth trauma, which can cause edema maybe on the head or of one side of the body. And of course, we talk of so delayed cord clamping means that we are allowing for blood to flow from the placenta to the baby. So delayed cord clamping can increase the volume of blood for the baby, and this can actually with increased volume, we know that there will be increased hydrosalpination. This can actually cause edema. So we want to see if maybe sometimes the patient can deliver from at home before they reach the hospital, and if they delay in cord clamping, there can be significant transfusion from placenta to the baby, which can predispose to edema. Then prolonged bleeding from the umbilical cord. This is just to check for liver disease, because we know that in liver disease, There is also bleeding diathesis, and in neonatal period, this manifests usually with prolonged bleeding from the umbilical cord stump. History. For baby with edema, we want to ask of the hoarseness of the voice. This is to check for hypothyroidism. Then shortness of breath or difficulties in breathing. This is just to check for heart disease. Also difficulties with breastfeeding is to check for heart disease. Then jaundice. This is to check for liver disease. Like I say, we know that if liver disease, there will be decreased production of albumin, and this causes edema. And also jaundice can occur with rhesus incompatibility or ABO incompatibility, and this can cause hydrops fetalis and anemia. With anemia, also any cause of anemia can cause edema, and so jaundice is important to us if you find a patient that is a neonate that has edema. Okay, to just rule out those causes. On examination, we'll just check whether the edema is unilateral or is it bilateral. Unilateral edema would think of trauma, and bilateral edema would think of systemic causes. Then if it's pitting or non-pitting, if it's non-pitting, we'll think more of lymphoedema, and the causes of lymphoedema, which you say Turner syndrome or Noonan syndrome. Then we check for signs of dysmorphism, and dysmorphism can be associated with renal problems, renal dysmorphism, and there's always a heart defect. Then, of course, petechiae is unlikely, but we'll talk of swelling of genitalia, which can occur with Dennis Drush syndrome. So those causes can actually show us that if we see petechiae, you may suspect sepsis. Okay, neonatal sepsis, that's severe. Vascular examination, you see, check for radiofemoral delay if you suspect Turner syndrome. The other signs of Turner syndrome, which include the webbed neck, and other things. So radiofemoral delay is a sign of coarctation of the aorta. Okay, so we can also ask for heart murmurs, do a full cardiovascular examination, check for any signs of congenital heart lesions. You may note that a bed, left to right shunts may not show a murmur. So you may not hear any murmurs at bed, but they may still be heart disease. So you may need to repeat this cardiovascular examination when the baby is about 6 weeks to check again when the differences in pressures occurs. Some of the murmurs will start to show around that time. So if you see edema, but investigations, echo and whatever can be done, but sometimes murmurs may be absent, even if with the congenital heart disease. Vascular examination, you see, check for radiofemoral delay if you suspect Turner syndrome. The other signs of Turner syndrome, which include the webbed neck, and other things. So radiofemoral delay is a sign of coarctation of the aorta. Okay, so we can also ask for heart murmurs, do a full cardiovascular examination, check for any signs of congenital heart lesions. You may note that a bed, left to right shunts may not show a murmur, and so you may not hear any murmurs at bed, but they may still be heart disease. So you may need to repeat this cardiovascular examination when the baby is about 6 weeks to check again when differences in pressures occurs. Some of the murmurs will start to show around that time. So if you see edema, but investigations, echo and whatever can be done, but sometimes murmurs may be absent, even if with the congenital heart disease. The investigations that we do, first, as part of examination, you can do urinalysis, just urine dipstick, or you can just check if there is presence of protein in the urine. Then that's to rule out nephrotic syndrome. Then we can do the full blood count, just check the hemoglobin concentration, because anemia and edema can cause edema. Check also UNDs to check for kidney function, liver function test to check if there's no liver disease, and check the levels of albumin. Then we need to do a full torches screen. Okay, so we can do RPR, but we need a full torches screen because we know that torches can cause nephrotic syndrome. Then a thyroid function test we're checking if there is no hypothyroidism. Then do a karyotype. And by karyotype, we're just checking the chromosomes, and this can show us if there's Turner syndrome, the 45XY karyotype. Then this will usually do it if we suspect Turner syndrome with other signs of Turner syndrome apart from the edema. Then the chest X-ray. This can show us left-right strands on chest X-ray can show plethoric lung zones. You can see other changes in the heart shadow depending on what is causing the left-right shunt. So chest X-ray can also show us if there is edema in the lungs. Okay, so pulmonary edema is another form of edema. So we can also check that and see if there's heart failure and other things. So we just need to do a chest X-ray if you see a neonate with edema. Then echocardiogram is also indicated.